Tom, can I just check that you've gone live? Okay, thank you.
Okay, so welcome everybody. We'll start off as we're waiting for Christie's interpreter. We'll just do the minutes and register of interests first. So we've got some apologies today. Rainer for being through, and I'm not sure if Joe Turn is able to join us for the public part of the meeting. Can you confirm that?
Yes, I'm here, Nick.
Right, okay, great, thanks, Joe. Okay, does anyone have any new declarations of interest? Great, it's perfect timing. Welcome, Tim.
Hello.
So, I'll just give Tim just a moment to settle down. Are you okay to start? So,
thank you. Christie's just trying to locate me at the moment.
Oh, right.
And I think we're all good. Hello. Yeah. Thank you very much. We're all pinned and ready. Thank you.
Excellent. So, good morning, everybody. It's me using my one and only bit of signing. I've run up to this now. So we're very pleased to have Christy Cooper here today to talk to us about her experiences of using the services from the perspective of a deaf person. So, Christy, it's you.
Hello, everyone. I just want to make sure everyone's on mute. That will make things easier. Just to make sure that the communication works well. Can I just check from the interpreting point of view? Can you all hear me? Is that okay? You can hear me. Fantastic. So hello, and thank you for inviting me today to the board so that I can talk about my experiences. Hopefully that will be a useful thing for you to take away, and an exciting and interesting thing, so that you can look at how deaf people can be supported better. So in terms of my experiences, it's a lot to do with when I book an appointment, whether that be at a GP or anywhere really. This is a really important phase for us. You know, we might want to phone, you know, our GP, and there's a gap there already because we can't use the phone. But this can be supplemented by something called VRS, which is called a video relay service. And one of these is called Sign Video. It's a fantastic service where you have a middle person that bridges the link between the deaf person signing and the GP receptionist being hearing, and they translate between the two communication forms. So that's a really big one to bear in mind. I will give you the links to this service. Darren, I'll give you that link later on, so that you've got the website. And if you wouldn't mind sharing that with the other members, that would be fantastic.
Yeah, no problem, Tim. No problem.
Thank you. So moving on, there are lots of issues regarding interpreters. Some people really do still prefer their interpreter to be face-to-face in the room with them. And this can be an area for improvement at the booking phase. I know the GPs have a system for finding out medical information, but there isn't kind of a flagging up system within those patient records or whatever it is, that comes up when the receptionist greets that deaf person, to think, oh, I need to remember to ask about this thing specifically. This person's deaf, but unfortunately that isn't on the patient records as a kind of easily flaggable thing. So if we were to have such a box, you could have information such as this deaf person likes to lip read, this person likes to communicate using gestural, this person likes to use an interpreter, or to write down the information. So I feel that that could be hugely beneficial. And I'd feel so much comfortable knowing that people know what I need. People do have a preferred interpreter as well out there, and it'd just be so useful for the GP systems to include this. So I don't know if it could go on a medical questionnaire form when people join the the GP, or it could be an access question, just something that includes the ability to check a box or fill in a comment box about what they need at this present time. Because it's so disheartening when a nurse comes up to you in the waiting room and just starts speaking to you, and they already haven't got the idea that you're deaf and that you can't communicate in that way. In terms of having a photo, you can't have photos in your records, can you, because of confidentiality? So they can't come out and know instantly who you are unless they already know who you are. So for the PALS complaints procedure, there is a gap with complaints procedure. There are very low numbers of deaf people who complain about any service, and that's really unfortunate, because there's just not enough mechanisms, and staff aren't clued up as to deaf people's awareness and their culture on how they can support people into making a complaint about their own service. This is hugely problematic. It's a bit of a challenge to think how someone can make a complaint if there isn't an interpreter there, or if they do, how long it might take for the complaint to get through. Something that I see popping up a lot is things pertaining to mental health. It's been there haven't been many support mechanisms for people with mental health problems, but I know the CCGs are starting to fund new projects looking at alcohol issues and counselling for deaf people. But I think we need some more specific funding for mental health, and I think some research needs to be done into this to look at how deaf people do access counselling. It's a very sad fact, but a fact nonetheless, that in Devon, I can only think of 2 people who are qualified to counsel people using sign language in the whole of Devon. You know, thankfully, because of technology and remote working nowadays, we can access counsellors from other regions, such as Scotland and Wales. But from my understanding, I think that there's maybe 25, perhaps 30 counsellors in the UK that are qualified with British Sign Language up to a level 6, which is the qualification you need. Can you imagine in the hearing population the numbers involved with, you know, how many different counselling services there are, drama therapy, anything? They're all out there. They're all lovely and available for hearing people, but for deaf people, we're still struggling to access these type of services. What we really need is just accessibility to be looked at. Maybe it could use sign video, the video relay service that I spoke about before. That might encourage people to start using counselling online. I'm thinking of my own GP practice. I've got the ability to use Relay UK, I think is the name of the particular service. Maybe you've not heard of that one. But again, Darren, I'll send you that email through to you so that you can have a look at that. But that's the one that I have to use. And it would just be nice if the local GP, my own GP's homepage, had something on it, just a small logo to say this is the one we use, either Relay UK or Sign Video. We've got the contracts with these companies, please. And then the deaf people will just see these 2 logos and be able to click on them instantly and be able to access a communication, a connection with their own GP. That'd be really lovely if we could see that. It's so visible, isn't it? Once you see those logos that you're used to finding, if you're a deaf person, it would be so navigable. Maybe a phone number on there or whatever, and then the GP service can improve the service. At the moment, we have to try and find some back and distant web page that does have the right information to guide us to where we need to go. A lot of deaf people do unfortunately get to the situation where they just can't be bothered to make that appointment. They think, what's the point in getting seen to if it's not there? And luckily there are deaf pockets in the UK that are still carrying on the fight to try and improve accessibility. I think it is just a challenging area that we're facing, this whole issue of access. And also the point of clear information on a website. I know we do have a long way to go regarding making information accessible, and it can be found, but it's quite hard to find. I just think it would be brilliant if we could have somebody. I know I'm not a doctor, I'm not medically trained, of course I'm not, but it would be lovely if we could find someone who could represent and give some feedback from the board about what is going on in sign language. I don't know how this could work. That's something that maybe, you know, we use sign language as our everyday language, and if we could have accessible information in this format, that would be lovely. I think it would help you too if we could feed back to you. And of course, we've got the vaccination programme. There have been a lot of changes from the government, and in terms of social distancing, self-isolation. It's been really hard to keep up with these changes in information for the hearing population. For the deaf population, it's been even harder to know what the rules are. If we can have that information in sign language, that would be wonderful. Maybe we can contact Sign Video to be part of this project. And there's also the UK Council of Deafness. I'll send you a link to this particular organisation. There are other links that I'll provide you with. So hopefully you just get a bit more depth of information from that. I know I've got so much to say, but I've tried to just focus on the most salient and important points. So appointments, accessibility, provision of interpreters, and the flagging system within your own patient records. Those are my key elements. I think I'll finish there. Thank you, everyone.
You're on mute, Nick.
Thank you, Christy. Do you have any questions for Christy, please? Simon.
So thank you very much, Christy, for this. I suppose I don't really want to. I'm a GP in East Devon, and I'm fortunate enough to have a partner who's deaf and also a practice manager whose daughter's deaf. So we may be in a fortunate position, but we have got those flags on the front pages of each patient. We've got a nice big eye. In fact, we have poppies for veterans, we have forget-me-nots for people with dementia, and we have an eye for people with sensory problems on the front page.
Yeah, I know the one you mean. Yeah.
Yeah, but what I don't have actually, at least I can't find it. If I can't find it, then it's a problem. I can't find very much on our website, so I'll take that back. But my wider point was, I'm one GP in one practice. How do we get this message to more GP practices? And I would maybe suggest that you have maybe an opportunity to go to our collaborative boards where all our GP clinical directors are, perhaps, who could convey some of this very important information out to a wider audience and a wider group of perhaps. But thank you anyway.
That's a really fantastic suggestion, Simon. I don't know if Christy's got time to take it up, but it would be a really good way of doing it, wouldn't it? Andrew, and then Charlotte, please.
Yeah, thank you, Christy, for brilliant insight. And I think all of the things that you outlined, and I've outlined about 5 things, I think are things that we could easily solve with a bit of effort. Because I think, we have, for example, a webcast with all of our primary care and GPs, and that could be something that we use to promote the message of what you say around sign video and Relay UK, etc. But the one thing I would do is an offer, really. We've started a lot of work around our equality and diversity agenda. We're trying to make sure that our services are more accessible for everyone. And perhaps if we asked you to be one of the leads for that work, I think we'd love to work with you in terms of how we take that forward, if that's okay with you.
Yes, that would be lovely. Yes, there is a lot more that I could go through, of course. We just need, as you say, whether it be a homepage on a GP's website to show the information, or when anyone have any ideas in terms of an equality and diversity group, those ideas are great. But as you say, and as you've suggested that I get involved, it needs a deaf perspective, because I've seen it before that such silly little mistakes that are easily avoidable can be rectified from an early stage, because people implement something and it ends up not working for something that they couldn't have foreseen. They're not deaf aware, they've not lived as a deaf person. But no, I'd love to be involved in that, if I may. Someone's muted. I'm not sure if
Charlotte?
Thank you, Kirsty. Thank you for sharing your experience. I just wondered, have you ever had to access services in an emergency? And if so, what was your experience? Or again, are there some very particular challenges that need rectifying in that situation?
Well, yes. My mum, when was it? It was about 1.5 months ago. My mum was in hospital in A&E, and we had to, everyone's wearing masks. Obviously, that's the policy. It does depend on which staff member you are dealing with and their individual attitude. Some are really good and obviously will remove their mask to be able to communicate with me. Some will. Some, unfortunately, are quite adamant that they are not prepared to remove their mask so that I can see their lip reading. So I can lip read them, sorry. And that's really upsetting, particularly. I was in Torquay because that's my area. And it would be nice if there was something, I don't know, it's really hard to book an interpreter, a face-to-face interpreter at such short notice. But if we could have some kind of iPad system available at reception, where an interpreter can be brought up on the iPad from one of these companies that I've previously mentioned. Just something at that reception phase would be lovely, so that I know it means another cost that you have to pay for, but that will be a discussion for the board, obviously. Hopefully it will come back as a yes. But yes, that there are in Sussex and Hampshire, they've rolled this programme out already through their CCGs, and all of the trusts over there have access via an iPad to a service like Sign Video. These kind of contracts make such an improvement to the deaf community. So it's such a wonderful experience. In terms of A&E, it was quite confusing. I don't know. We need some kind of clarity of information for us. There is a barrier there for deaf people. I know everyone has different needs, and I know that can be difficult to try and implement something. If someone's already hurting, already injured, trying to get them to communicate can be difficult at the best of time. And if a person's laying on a bed, you can't hover an iPad over their face and expect them to communicate clearly. I don't know what the ideal solution is and how that can work, but for hearing people, when they're hurt, they can close their eyes and they can still hear and they can still speak. But a deaf person has to try and hold their eyes open even though they're in such pain, and that action alone can be hugely problematic. Just food for thought.
Thanks, Sheila. Sheila, please.
Yeah, thank you. Hello, Christy. I'm Sheila. I'm a GP in Plymouth. I just wondered whether you had any personal experience or whether you've heard of any deaf people's experiences with the clear masks that were apparently made available in certain situations. I understand that there weren't very many that were provided. Yes, but whether deaf people have found them to be helpful, or whether they just steam up and get soggy.
Yes, thank you. It does depend. Some deaf people are enjoying not enjoying, that's the wrong word, are in favour of them. You do have the issue of the condensation building up, and people can try and keep them clear, but again, it depends on the deaf people's individual choices. But they can work, they certainly can. Personally, I find them not very nice to try and use. I'd prefer someone to just quickly remove their mask and put it back in place. We're all human at the end of the day, and I understand why some people do and some people don't want to do so. But also, just to keep you in the loop, I've worked with deaf people in different areas for 12 years, and I myself am a trained deaf advocate, and I've campaigned in many areas and in many different projects. And one that I've just started this week and might be useful for you to know is a project called the Community. Sorry. So a deaf community vaccination champion. Sorry. So the Deaf Community Vaccination Champion, which is a new project that's being rolled out this week, and it should be quite an interesting thing. I think there's going to be a 6-month project. So as more information comes to me and how we realise how this area can be improved, I will let you know. And that's a journey that I'm going on myself at the moment.
Okay, and finally, Jane, please.
Thank you, Kirsty. I'm Jane. I'm the Chief Exec of the ICS and the CCG. So listening to you, and I think there are some really clear things we can take away, aren't there? You've given us a fantastic to-do list in relation to getting our GP websites. Actually, I can't believe it's not statutory that we have to comply anyway in relation to access, but even if it's not, we can take that away. The vaccination.
There's nothing, unfortunately. No.
Well, but we can make it a Devon commitment, can't we? So I think that's important, and I think the vaccination work will be really good to follow up, as well as you say, the work. Some simple things to put in place. To some extent, getting iPads is easy. But it's still the cultural shift. We need people to understand that. So there's a bit about how we take that. And I think we've been doing a lot of work in terms of developing our health inequalities networks. And one of the gaps we do have is an ability network. So we'll be knocking on your door to help with that, because we need to set it up across Devon. But thank you.
Lovely. Thank you. Thank you. That's great.
Okay, and I've got Darren finally. Darren.
Yeah, apologies. I'm having issues with my raising of hands. So, Kirsty, thank you so much. And I'm Darren Hawkins. I'm the chief nurse, but I also lead the vaccine programme. So, yeah, hearing your comments there, and I'm really pleased to hear the introduction of the vaccine champion, because I think for us it's been a real challenge in pop-up centres, remote, all of those challenges. So really looking forward to working with the vaccine champion. We have also used the video system, which I say it works really, really well. So I think really just to advocate to other colleagues that that has been successful in some of our vaccine clinics. So thank you for your time today.
Lovely. Thank you so much. It's been a fantastic opportunity. I'm really pleased to have been involved. Darren, I'll send you those links that I said I would, and if you can disseminate those to people that need them. Thank you so much.
Okay, thank you very much, Christy. That's been a brilliant presentation, and you've given us a lot to think about. Thank you very much for your time.
No problem. Thank you very much. Okay, thank you all. Thanks for inviting me. It was a pleasure. Thanks.
And thank you.
Thanks. You both said it at the same time. Thank you. Thank you. Thanks, everyone. Lovely to be here.
Okay, then let's move on to the minutes of the last meeting. We'll just run through them quickly for matters arising and matters of accuracy. So page 1, page 2, 3, 4, 5, 6, 7, 8, 9, and 10. Well done, Nikki. That's very good. And then that takes us on to the action log. We've got 4 open actions. So the first 2 are yours, Simon. Do you want to tell us what the position is on them, please?
So the first one, I don't think we've shared the recovery support program minutes yet. Jane, I didn't have a chance to discuss that with you. Is that okay to share via Nikki and Annette?
Yeah.
Yeah. So Nikki can hopefully take that action.
Okay.
And I did mention to Darren, I don't know if Darren and Charlotte have had a chance to catch up. No. Okay. I'm sure it's in hand.
Yeah. Okay. You've got about 24 hours, Darren, before Charlotte will be gone. And then we've got 2 for Joe, number 3 and number 5.
Hi, thanks, Nick. So the first one, so I can confirm that we've taken the feedback that we got. So there were several bits of feedback last time we were here. So one was around the green agenda. Very confident that we're aiming high in terms of meeting all the national standards and going beyond that, actually. And also some of the comments that were taken around things like lifts, stairs. So stairs being prominent, but making sure we've got enough lift access, etc. We've taken all of that into account. So I've gone back, checked that with the design teams and with Clive, who's the programme director. So very happy with that. There is another action further down, which is about a wider action about primary care in Plymouth and what that looks like. I think that's part of a bigger piece of work around the strategy refresh, which we have agreed that we need to do. So I've had a couple conversations one with Judy, this was back in the summer, one more recently with a few members of the exec team, which was just an informal conversation about wanting to revise the strategy. So that is something that we're going to look at over the next couple of months. We'll probably want to do something now in January, but need to obviously have those conversations through primary care committee, etc., in order just to set that up.
And just in case anybody hasn't seen it, Andrew's just posted a note saying that this is going to be covered at the development session next week as well. Okay, great. Thanks, Joe, very much. Okay, just before we move on to the clinical chairs report, I just wanted to say a couple of words, because we are losing today 2 extraordinary individuals from our GB, and I just would like to record my thanks to both of them. So firstly, Charlotte. Charlotte's been with us 2.5 years. Charlotte, you represent a number of groups that are not well represented at board level across the NHS. First of all, you're a mum with young children. They're very rare in non-executive director roles. And also you're under 150 years old, also very rare in non-executive director roles. Joking apart, you're considerably under 40 still, and that is extraordinarily rare in non-executive director roles. You've brought a completely different perspective to our board. I've learned so much at a personal level. I've learned so much from you over the last 2.5 years, because you think of things in a different way to all of us old geezers who've been doing corporate stuff for so long we can't remember how to do anything else. And you have challenged us and raised the profile of maternity services, which I know is a particular interest to you, and you've consistently spoken up for the patient. So I'd just like, on behalf of everyone, to say a huge thank you for everything you've given to the CCG over the last 2.5 years, and we wish you well, and AHSN's gain is definitely our loss. Thank you, Charlotte.
Very kind. And just to quickly say, I've really appreciated my time, and the learning has been mutual. So I've taken a huge amount, and I will take the learning that I've taken from lots of you, all of you around the table, to my future role as well as future jobs. So thank you.
And then today is also Dame Susie Leather's last meeting with us. So is it 2.5 years ago, or was it even longer than that?
3.5.
Yes, time flies, doesn't it, when you're in the middle of COVID? So if ever there was an impossible task to take on, it was the role of the nascent ICS chair, and you've done a fantastic job of particularly bringing health and local government in Devon much closer together than they were before you took up your role. I've always found you to be intelligent, able to bring people together from different perspectives, and a fantastic communicator. And you've really moved the agenda forward for Devon, and we'd all like to thank you for that.
Nick, that's extremely kind of you. I mean, I just want to thank you all, really, both the governing body and the staff of the CCG, for your professionalism, but also your personal kindness to me. Thank you for allowing me to attend these meetings for the last few months. It's been really great. I just wanted to say that despite the very precarious position I think that the NHS is in at this time, I still feel really optimistic about the future. I think the ICS is the right way forward. But more than that, I think we've secured in Jane and Sarah as the leadership for the ICS, a really fantastically powerful leadership team. And, I think we should all be supporting them going forward. And thank you very much.
Thank you. And finally, before we move on to the clinical chair, I just wanted to put on record my personal, and I'm sure the whole board's, pleasure at the fact that finally Jane has been confirmed in post as the ICS Chief Executive. We knew it was always going to be you from 6 months ago, Jane, but in the NHS, process has to be worked through, doesn't it? And so it's good to get that finally settled, and so I'd like to officially welcome you to the ICS. Thank you. Okay, so let's move on then to the clinical chair's report. Paul, please.
Now then, I don't know.
No, I've just arrived back, Jane.
Oh, well done, Paul. I was just about to pretend to be you.
That's all right. No, I've just walked back in, so apologies. I had to be out in the car, but I've been listening in, particularly to the first item, which has been really valuable to hear. I'm not going to go through in detail. I was going to say what Nick has already said, which is that really, a thank you to Susie. A really, congratulations to Jane, and actually, it's really good news that Jane is continuing in that ICS leadership role. And the other thing, and I suspect Jane will add to this as well, is to be really pleased that Sarah Wollaston will be joining from the beginning of next month in that chair role. And I guess from a clinical chair's perspective, the bit that I'm really pleased about is the two most senior leaders within our system are both clinicians. And I think that sets the right tone for us as a health and care system, and makes me very optimistic about how we are going to work effectively, combining the managerial and executive expertise that we have within the system with the clinical leads and clinical experience that we have as well. So I think that puts us in a really strong position. So a thanks to Susie, a thank you to Jane, and welcome and keep going, and a definite welcome to Sarah. And then the other thing was, it was a delight to be part of the staff awards at the beginning of the month with Jane. It was good fun for us, but I think most importantly, it was really nice and really rewarding to have seen so many examples of great work from our staff in really tough circumstances. So I guess in this public meeting, it is about saying thank you to all our staff, particularly those who won or were nominated, but actually they represent, just a small proportion of the immense amount of hard work that has been going on within our organisation over the last year. Thank you, Nick. That was all I was going to pick up, but happy to take questions or comments.
Okay, are there any questions for Paul? No. In which case we'll move on to the Chief Exec's report, and Jane.
Well, thank you, Nick. And just to say, I'm sure there'll be other opportunities, but I'd personally like to say thank you to Susie, who has been fantastic in supporting me in the last, whatever it was I've been doing since April, and now I'm doing there. So But no, thank you. And obviously, yes, to some extent, Sarah, I think, is already starting to sort of get going, but officially doesn't start until the 1st of December, which is actually next week. Goodness, I can't believe we're in December. So I know that she will be starting to, if she hasn't already, be getting in touch and undertaking some inductions going forward. So I wasn't really going to say anything more other than just to say, obviously, a bit of an update in there about the ICB development. We're still managing to sort of move that forward, which is not without its challenge given the operational pressures, but actually also given some of the changing national guidance, and of course the Health and Social Care Bill is still going through. So for those of you who were around when we had the last set of changes, you'll know that this particular time of that progress often will possibly result in further changes. So we've just got to be agile. In terms of vaccination, I just want to say just a thank you to Darren and the team and all of you actually who are involved in this. It is incredibly challenging, and we are doing an amazing amount of work in this space, and our vaccination rates are really fantastic, but we do know that we've still got gaps and people who are still to be vaccinated who unfortunately perhaps are popping up in our hospitals at the moment. So further work on that will continue, and I think Christie's sort of reflections are really good, isn't it, about how we still have to focus on some people who perhaps are challenged in terms of accessing that. Again, just a little bit of an update there about mental health, and also we might come back to this later. We have reflected and put in place, I think we recognise this particular time in the NHS and going into winter, although I think winter started on the 3rd of July for Devon, is probably, and I'm sure others will agree, the most challenged time of the NHS, certainly in my career, and I've been in it for quite a long time. So we are trying to put in place and refresh our collective approach, both at a system level, but actually supporting organisations and also working across that health and social care and voluntary sector aspect. But I do think certainly we will probably come back to that later. And then again, just to echo what Paul said about the staff awards, really important just to take stock and to thank people, and not just, as I say, the people who received awards, but all of the people who took the time to make the nominations. And yeah, I think I just about got rid of all the feathers in my office, and so that was great, and it was a real pleasure to be involved with that. So thank you.
Okay, I personally was really pleased to see the bit in your report about the new Prince View facility giving the psychiatric assessment and treatment of women. I think that's been a real gap in Devon, so it's great to see that opening. Any questions for Jane, please? No? Okay, in which case we'll move on to, sorry, Simon.
Sorry, thanks, Nick. Maybe I don't know whether it's one for Darren, but could I just ask about the plans for the housebound, for the vaccinations for the housebound? We've had to decline that in our PCN, and we've passed all the people that we know about to the CCG, and I'm waiting to have some clarity about how we're going to do that. The problem, for those who don't understand that, is that with the Pfizer vaccine, which we're administering, there has to be a 15-minute observation period afterwards, and that's proving to be quite difficult. But I don't know what the plan is going forward.
Do you want me to come back on that, Chair?
Yeah, that'd be great. Thanks, Darren.
Yeah, so I think absolutely right. So as it stands at the moment, Simon, we've had just over 7,000 individuals passed back or passed forward to the CCG from PCNs across Devon. We've achieved 36% of those as of today, another 20% over the next 2 weeks. So we are picking this up through our roving pop-up models. So we're obviously using our existing resources to support those, also using some of our voluntary sectors to help with the observation period. There is a potential that we can now start to use AstraZeneca as well in individuals that have been first and second dose to AstraZeneca. The Green Book has just changed. So we're looking at availability of AstraZeneca to support that, because obviously that will enable us to quite rightly expedite that programme for those individuals that are distance, remote, and obviously very isolated and vulnerable. So absolutely, our plan is to address all of those by 23rd of December, I think the plan is at the moment.
Okay, thanks, Darren. Any other questions for Jane? No. Okay, then let's move on to the programmes of work section, starting with the financial plan for 1st of October to 31st of March. John, please.
Okay, thanks very much, Chair. So as I've got the mic, I'd also like to follow suit and thank Susie for the support and guidance that she's shown to me. As I'm talking about a financial plan, I was particularly reminded of a memorable trip to Chippenham that we had in the very early days of your tenure, Susie. So
yes, I remember that as well.
Yeah, I'm pleased to say I've got a slightly better set of numbers to talk about today, but there's some things that lie behind that which I'll also cover in the report. So what is presented today is the financial plan and budget for the CCG for the second half of the 21-22 financial year, starting on page 33 of the pack. I'll just canter through it and try and pull out some of the most salient points, I think. So worthwhile just noting the changes to the allocation. So this is the changes, significant changes between H1, first half of the year, and the second half of the financial year, and those are set out just at the foot of page 35. So just noting really that the impact of the pay award, which has now been made to everyone across the NHS, across the system, that was funded fully in the allocation. Although as that was worked through, there was a slight shortfall, we think, on the impact of the pay award and the funding that we've received. So that's had to be managed within the overall allocation. Significantly, COVID funding, specific COVID funding, is starting to reduce, and we've seen a 6% reduction in the funding available between H1 and H2 across our system, specifically to deal with the additional costs being driven by COVID. Requirement for efficiency is starting to come back onto the table as part of the overall ask of the health service. As it says in the notes there, 0.28% we were required to deliver in the first half of the year. That's increased to 0.82% for the second half of the year, so 1.1% across the whole year taken in aggregate. And then importantly for us, a further reduction to resources for those systems who are furthest away from their financial improvement target, and I'll say a little bit more about what the impact of that has been. Just moving across to the top of page 36, then some other significant points to note. Quite a bit of funding at the moment, specifically targeted to support elective recovery. So waiting lists have increased significantly during the COVID period, as we all know. Some money available to specifically target reductions in those where it is possible to do so. Each of them can't resist having an acronym, so the Transformation or Targeted Investment Fund, the TIF as it's called, and Elective Recovery Fund, ERF, are available and supporting our plan, although not part of the envelope that's set out in this plan. And then finally, importantly, the hospital discharge programme, which has allowed faster discharge from hospital, does continue for H2 as an external source of funding. That will come to an end at the end of H2. So we are working very closely with local authority partners on both the financial impact of that, but also the operational impact and how we keep the best of what we've been able to achieve through that source of funding through hospital discharge programme. Little bit of detail in table 1, which I will dwell on just because it sort of sets quite a clear context, I think, for our current financial position, but how that's likely to change. So there's significant points from table 1. If you look at the penultimate column for H2, it shows our overall allocation for the system of just over £1.1 billion. That's set alongside the allocation that we got for H1, and what you'll note from that is it's a reduction in funding from H1 to H2. If you look across the rows, then what that also confirms is that in this current financial year, as a whole, as a system, we will have received an additional £132 million of so-called top-up funding and £120 million of COVID funding. Both of those sources are non-recurrent, and to some extent, as you can see between H1 and H2, they are starting to reduce. We anticipate that they will reduce further as we get into 22-23, and that in essence is what's framing the financial challenge that we've got to get back to in the 22-23 year. But just for a moment, we'll just dwell on the second half of this year. I'll move us on to top of page 38. In table 4 there, just a point to pull out. Where we have been for the entirety of the previous financial year and the first half of this financial year is we've received an allocation as a system. We've allocated that out to all of our constituent organisations, and everyone has planned to deliver financial balance. What you can see from table 4 across the system is in H2 of this year, we've taken the same approach to allocation of the envelope, but in terms of what's happening in the cost bases across the system, it's left us with a series of at organisational level, a number of surpluses and deficits, which are netting off to an overall system aggregate of 0. So as a total system, we're balanced, but some organisations are planning for surplus and some organisations are planning for deficit, and that is quite an important principal point, because it is a good illustration of true system working, that some organisations are working to provide a deficit to offset, a surplus to offset a deficit elsewhere, rather than pushing ahead and spending that money, and that's important from the perspective of keeping the whole system in balance. Just moving on then to the specifics of what I'm asking in the paper. There's some more contextual information set out, which I'm very happy to pick up questions on. But if I cut to table 7 in the paper, those are the CCG operational budgets for H2, which we're asking governing body to formally approve. So that's the part of the system allocation which the CCG spends directly on services out with our main NHS hospital providers. So a total of 409 million of allocation that we have for the second half of this year will be deployed according to those budgets, and will result in an overall surplus for the CCG of 1.6 million and a system contingency which we hold on behalf of the system of 3.7, taking up to an overall surplus which will contribute to that overall system position of 5.3 million. Last thing I will mention before I open for questions is the efficiency position for the CCG that's inherent in that overall surplus that we're planning to deliver. So table 8 in the paper sets out a total of just short of £14.4 million worth of efficiency that we need to achieve. Table 9 puts a bit more context on that. So of that total number, 6.5 million of that we deliver at the plan stage effectively by taking the allocation and not spending it. So that immediately delivers that part of the efficiency programme with no risk to delivery. That leaves a further 7.9 million where we do need an efficiency programme, a savings programme that we would recognise in the traditional sense, which we have reinstated the mechanisms within the CCG that we've had in place previously to deliver that. And we've got savings targeted through the areas of medicines optimisation, running costs, our use of the independent sector where possible, and a fourth one which I've just forgotten, but Simon Tapley will remind me of, and just has. Thank you very much. So those mechanisms back in place. Challenging environment to get savings, but the mechanisms are back in place, and that's important for the second half of this year, and also to give us a good start into 22-23, which, as I've said, is likely to be more financially challenging. That's probably all I need to say, Chair, but I'll pick up any questions, but formally asking for approval of the budget for H2. Thank you. You're muted, Nick.
Can't get my unmute button to work for some reason. Right. Thank you, John. Has anyone got any questions for John? Judy, Glynis, and then David, and then Simon Kerr, please. So Judy first.
Mine is just quickly, we've had experience of having efficiency plans which we've relied on, and then they're not met. And I would like a sort of executive team comment on how probable is it that we will meet this 14,370 figure?
Thanks, Judy. I might ask Simon to come in for a sort of wider comment. I mean, I'll just reinforce the point that the quantum of the 14.4 that there is some financial risk associated with comes down to 7.9 because of the action we're able to take at the start of the year. So 7.9 is the full extent of the risk if we didn't deliver everything. We've also set out in the paper a sort of series of risks and mitigations. So we have made an assessment that there is a risk of about 5.5 million as we sit here today to delivery of that full amount. So quite a significant risk. Our approach to that will be to look for other mitigation from the entirety of what we're spending, but it is important that we just get a little bit of momentum back up in the savings programs. And in terms of process, that's perhaps where Simon can offer an additional word or two.
Yeah, thanks, John. So Judy, we've made the savings in the independent sector. We're not expecting to make further in the second half of the year because we are trying to catch up waiting list, but we've secured the savings we need in the first 6 months of the year. In terms of CHC, I think that will be a bit of a challenge because of the hospital discharge programme and the catch-up required, but we are working with Liaison who are providing some additional capacity for us to work through that. Meds optimisation, so Joe's on the call. I think we've got, as you'll know through PCC, we've got a bit of an issue with vacancies in the meds team at the moment. So we've got some plans in place, and the achievement in the first 6 months of the year that becomes recurrent gets us over £1 million. I think there is some risk around the second £1 million for us there, but as I've said, Joe's in the process of starting recruitment. I think we're also concerned about the capacity in primary care to actually be able to transact some of the changes that we'll need to make. In terms of running costs, we're already holding a number of vacancies. So the calculations we've done, even if we were to fill those vacancies over the course of the next couple of months and with notice periods, etc., we'll achieve the savings target that we need to. The real issue for running costs is how we move into 22-23, because I think we've talked about staff well-being and how busy people are. We do believe we need to fill those vacancies. So I'm probably 70% confident with the savings plans we've got, and John and I have set up an exec oversight group. So John, myself, and I think we were going to have a conversation about whether there was enough time for a non-exec colleague to join us. And obviously delighted that Andrew, Joe, Darren and John Finn are exec leads for those savings plans, and they will join us to be scrutinised and supported in equal measure around how we achieve those plans for the rest of the year.
Thank you.
Okay, thanks, Judy. I've got Glynis next.
Yeah, my question was also about the efficiency plans in Table 9. The last section, which says unidentified efficiencies, is that the 6 million that you says was sort of baked in from the beginning, John, or does that still have to be achieved?
That's the bit which does need to be achieved, Glynis, where there is some risk. The bit that we achieve at the outset of the plan are the ones in that table that are shaded green.
Right.
So the unidentified is the biggest part of the risk, if you like. So that's the stuff where we have to do real things and difficult things to get them.
And we've only got 4 months to do that.
Yes, yeah, absolutely. I mean, we're not starting. We're not starting from a standing start. So although unidentified might be a slightly harsh way of putting it, we've got the areas that we're targeting and we're making some progress with them. But it's just that they are high risk. There's no getting away from that.
Okay, and just to be completely clear in my own head, then that's the area, Simon, where you have something like 70% confidence that you'll achieve.
Yeah, and so if we take the bit, so John said we're not starting from a standing start. So things like the independent sector, where we underspent in the first 6 months of the year, I don't think John is included in the table as even amber, is it? It's still in the red section. So we've got a good contribution already towards that 6 million.
Okay, thank you.
Okay, thanks, Glynis. David, please.
Thanks. I just wanted to understand how suspension of elective care in a DGH affects the financial position in two ways. Firstly, is there a saving associated with the suspension of care, or does the increased emergency care knock that off? Is it part of a block contract so it doesn't affect us anyway? And finally, how does it affect the elective recovery fund?
Thanks, David. Yes, so the I probably won't get these in the right order, but the simple part of the question was from our perspective, from CCG perspective, the flow of funds to the acute sector providers is entirely block, so there's no variability from our perspective. There is variability with our direct CCG relationship with the independent sector, which is relevant to your point about elective recovery fund, but it is that is completely variable in the sense that if we're not able to do the work, or if the independent sector is not able to do the work, then we won't earn the money from the elective recovery fund, but neither will we pay it. So although it's not great from a care point of view, from a financial management point of view, it's entirely neutral. The more difficult part of the question is what impact does that have in the acute sector, so in our partner organisations, where if they're not able to deliver the care, then there may be a marginal saving, but it's probably not very much because the staff will be deployed into urgent care and all of that sort of thing. But they also then won't earn money that they're anticipating from elective recovery fund. So that scenario does create a financial management challenge for the wider system, although it doesn't impact directly on the CCG. You're mute again, Nick.
I'm continually hitting the button and it won't unmute me. It's weird. Sorry, everybody. Simon Kerr, please.
Yeah, thank you. So for John, you just said it would create an impact on the wider system, not for the CCG. What happens if we get into January and February and those anticipated outturn surpluses and deficits have gone astray? And the providers are not going to realise those savings and those deficits. And just one for Simon, if I may, I think you mentioned that you're worried that the continuation of the hospital discharge plan money may have some impact on the anticipated CHC savings. Do I understand correctly that the hospital discharge money is kind of ring fenced until the end of March, and therefore why would it have any impact on the CHC's anticipated savings?
Do you want me to do that one first? So the fund is only for 6 weeks, Simon, for each individual. So then you have to do an assessment to look at whether it should be NHS funding going forward or social care or a mix. So as we go back and do the backlogs, there's obviously a backlog has built up whilst we've been doing it. As we go back and do the backlog, if more than we have anticipated or budget for turn into NHS funded, that's the risk. Because that's right, Darren, isn't it?
Just come off me. You're absolutely right, Simon. It's that 6-week review that actually could be a positive or negative, but ultimately it's the right thing to do for patients as well.
So there's some really complex conversations having to be had with local authority, particularly as we go into next year and beyond, because we've got a sizable risk, I think, in the east with that pot of money.
There's some macro discussions required. I think we've always had complex discussions with the local authority. I think we're getting towards, and I think hospital discharge programme has helped us with this. We've got towards the funding of pooling of budgets properly for this this type of cohort of people, particularly with Devon County Council. We're sort of in that place already with Plymouth and Torbay. So I think it's sort of given us another nudge along, and actually having an end point, almost a cliff edge, will hopefully will sort that out for us.
Okay.
Hopefully.
Okay. Then we've got
Nick. Sorry, there was a first part to Simon's question, which
sorry, yes, go on.
Which I'll come back to, which is in financial impact of things like if we don't earn everything we're expecting from ERF and people start to go off plan, there are still quite a lot of moving parts in the overall financial equation. Each organisation will be expected to deliver the plan that it's now signed up to, which sits within that overall system plan. We've got and have had in place a sort of collective approach to financial risk management. So if an organisation gets to a position where it's looking at serious risk of not being able to do that in aggregate, then that will prompt a system conversation about looking for offsetting benefits and contingencies that we can bring in from elsewhere. So it will be difficult, but as I say, there are quite a lot of moving parts in there, but a system-wide commitment that that is the way we would handle it.
Okay. Thanks, John. I've got David and then Graham.
Sorry, that's a previous hand, sorry.
Okay, all right. Great, thanks, David. Graham?
Yeah, I just wanted to take the public opportunity to thank John and his team for getting us this far in producing the H2 budget and for the work across the system and with system partners. And to reflect perhaps on what Simon said about, the team of people who will be coming together to deliver the efficiencies. I think Simon says with equal support and challenge. And let's just reflect for a minute that those are the same people who were asking to deal with the intense operational pressures at the moment, deal with winter when it comes, even though it did start on the 6th of July, transition to the ICB and sort out waiting lists and elective recovery. You just wonder what they're going to do in the afternoon, really, don't you?
Yes, indeed you do, Graham. Okay, any other questions for John? John, do the providers have a version of table 7 for each one of them?
Sorry, Nick, just repeat that. So,
do you have a version of table 7 for each of the providers?
We do have it collected in the as part of the system plan. Yes, in terms of how each provider's operational budget is set up. Yes, we do have access to that, and indeed, they'll take the equivalent of this through their boards in the same way as I have.
Right. Okay. If I could have sight of that, that'd be really interesting, please. Okay. Sure. Thank you. Right. Let's move on then to the what's up with my agenda? To the integrated quality report. Darren, please.
Yeah. Thanks, Chair. So I'll keep this very high level. I know we've had detailed conversations through a number of the subgroups and over the last few weeks. This is the latest iteration as we move from separate quality performance, etc. reports into an integrated performance report. So hopefully what you're starting to see now is, I think a few people have alluded to a bit of a State of Devon type narrative based on the facts and based on the data. Presentation will evolve over the next few months as we now bed down the data. There are still a couple of gaps in terms of safeguarding and community to give us that true rounded picture. But I think as we've already talked through governing body today, I think this continues to reflect the continued pressures that our teams, particularly our acute providers, both in acute physical health and mental health, also the challenges that our primary care teams are seeing, as being very sustained over particularly through last winter, through the summer months, and into this winter as we fast approach. I think I'm not going to spend a huge amount of time going through this line by line, because I think there's a very clear narrative there, and we're very excited on the urgent care challenges, the elective care challenges, and those particular areas. But I think a few areas just that we probably don't talk about frequently, particularly at governing body, are some of the other challenges. So I think as you see going through here, particularly we talk about infection prevention control. Very focused, obviously, quite rightly through the pandemic on COVID. But when we see some of our challenges around E. coli, particularly as Devon being an outlier across all of our providers, again, what we'll start to look at through these reports will be the impact of support, impact of systems, impact of programs. So some challenges there around infection prevention control. Obviously, the report goes into quite a lot of detail around the urgent care pathways and their particular challenges at the moment. We know there's a lot of work going on there, particularly across the whole pathway from primary care through the hospitals, through to discharge, and actually how we support our colleagues in SWAST and prevent ambulance delays as well. Obviously, again, there's detail in there around the referral to treatment times. We've obviously seen an increase in our diagnostic requests, but actually we've seen an increased performance in diagnostics. I think that's an element that we need to take time and reflect on actually as a positive, because ultimately, as we get better with our diagnostics, ultimately that helps us in terms of reducing harm, mitigating some of the risk, because actually we now understand individuals in terms of what pathways patients may require. And obviously we're also seeing increased capacity coming online through the accelerator programs, so we're expecting that to continue to be an improving picture. Other challenges are the 2-week wait referrals have increased. They're now at 125%. So there are real challenges of that across the whole system. Discharge flow is another area. So when you look at these elements here, we have a large number of individuals that are awaiting discharge, and that is a real area of focus across health and social care. And we've seen some real impact, particularly within our locality teams, around different approaches to domiciliary care, how we support elements such as care hotels and those sort of areas to ensure that individuals are supported in the right area to the best that we can, recognising some of the workforce challenges. If we move on to children, young people and families, again, we remain concerned about our autism referral weights. And again, there is a significant amount of work that we're doing with Children's Family Health Devon to improve those trajectories. And again, we have reported those plans and are being reviewed, and we talk about those also again through our Quality Assurance Committee. Maternity wise, again, we do always see through August, September an increase in demand. That has been even greater this year. So some of the challenges, we look at some of the better births numbers, and particularly we look at some of the staffing ratios. It's worth noting in the report there are some percentages in there which actually are related to shifts where there are challenges around nurse or midwifery to birth ratios in terms of the planned have been below where they should be. However, it's worth noting that those are pre-mitigation, so through our the local maternity and neonatal system, and through our work with all our maternity units, we're absolutely sure that mitigation is in place. And some of the areas, particularly around in the summer, around challenges around elective cesarean sections, we worked very well as a system to ensure that those individuals were supported to the best they can. Obviously, again, since the last time we've talked about any of this detail at Governing Body, we have seen a number of never events across our organisation. So we have reported 5 across our providers in previous months, and we'll continue to look at the thematic analysis and support around those particular areas. And I think the final thing for me to note is the workforce figures. So we are seeing a continued challenge around our turnover. So turnover has increased as we've started to move, into sustained pressure out of probably the first and second waves of the pandemic, and that is also coupled with a moderate increase in sickness. So again, I think one of the elements we need to be really clear here is that we are obviously seeing challenges across all of our system. We are working as an integrated care system around mitigation, but ultimately, the workforce remains under significant pressure, and the elements around supporting individuals to remain well at work become as important, if not more important now than ever. But probably that's all I would draw the governing bodies to attention to, Chair, and I'm happy to take any questions.
Okay, thank you, Darren. I see Sheila has learned to be quick off the mark. So,
finally.
First go.
Thank you, Nick. Thanks, Darren, for your report. There's a very stark statistic in your report which details that only 20% of care home staff have had their flu jabs. And then later on in the report, you talk extensively about all of the things that we're doing to improve support for care homes so that they can improve their capacity, dementia step down placements, etc., etc. We learnt during the first wave of COVID, didn't we, the implications of discharging people who were very vulnerable from hospitals into care homes, and sadly saw a lot of losses and illness and deaths in some cases as a result of that. I wonder whether we are missing an opportunity here. Certainly, I think the government missed an opportunity in not being more directive about the importance of flu jabs in the care setting, and I wonder whether there is anything that we can do. What are we confident that we're doing enough to support our care home staff to understand, rather than a direction, to actually understand the implications and the necessity for them to be vaccinated themselves? This is not, by and large, a group of people, is it, who understand health issues from a professional point of view. They're care staff, and they may well be frightened or wary, and I just think we're missing an opportunity and not doing something much more proactive about supporting them to get those numbers up much more highly.
Yeah, thanks, Sheila. And I think it is an absolutely appropriate and fair challenge. And actually what we've doing over the last month or so is we've brought the flu programme and the COVID vaccination programme together into a seasonal programme. So we have within the programme board a care provision cell led by our local authorities, and this is absolutely the area that we're focusing on with those individuals. So we're using our vaccine hesitancy nurses to go out and support care homes elements. We're using a number of videos, but equally we're also working with local communities, recognising that there are a large number of individuals working within our care homes that English is not their first language. So there are a number of areas with our inequalities cell, again within the vaccine programme, working with community groups to ensure the right information and support those individuals to access not just the flu vaccine, but also the COVID vaccine as well, because we are seeing hesitancy in both of those, particularly the seasonal flu and also in terms of the boosters. So that's the area that we're focusing on and giving a lot of scrutiny on a weekly basis at the moment.
Thank you.
Thanks, Sheila. Alison and then Charlotte, please.
Thank you, Nick. Darren, firstly, I really like this new report. It makes it much easier to understand everything that's going on in the system. But I want to take you back on two things you mentioned briefly. We had a snapshot of people who were medically fit for discharge on one day, and I could see a lot needed domiciliary care, and we're talking about trying to increase domiciliary care. But over a third of the people were wanting pathway to rehab or reablement in some sort of care hotel. And I wondered what we were doing to try and develop further resources there.
Yeah, so we, again, within the winter room, there is existing and will be a more robust cell discharge pathway. So what we've seen in lots of our community, in lots of our areas, having so Plymouth is a good example where we have increased the care home or the care hotel capacity. What we're also doing is working with a large number of our care home providers across Devon to understand where beds are not able to be opened at the moment, which is generally, again, a large staffing issue, working with our winter funding and working with our local authority elements. So there are plans afoot at the moment to open, and are currently across Devon, 68 beds that are currently not able to be opened because of staffing, similar numbers in Torbay and a slightly lower number in Plymouth. Coupled alongside that, though, is making sure that our reablement pathways are robust, how we support our community teams, both in terms of in-reach, because if we don't get the reablement right, actually, all we do is move those individuals without the right level of support from a hospital bed to a care home bed or a care hotel bed. So it is not just as simple as creating more capacity, because ultimately that isn't easy, but we are doing that. It's ensuring that we actually have the right reablement, rehab pathways supported by the right individuals to actually ensure that those individuals don't decondition and are then supported in the right place, hopefully their own home in the main.
Okay, thank you. And it wouldn't be quality report without me emphasising my concern about the ASD waiting list for children. And I Absolutely. Did notice the stats are saying that in September it was still an 85-week mean wait for someone for an assessment, which is exactly the same as what it was back in April. So I'm still really concerned about it.
Yeah, and I absolutely share your concerns. As I say, we continue to work with Children and Family Health Devon, and I believe, I'm looking at Glynis, I believe that we have got that back on the agenda for the December meeting as well, because as you say, the trajectories remain static rather than improving at the moment.
Okay, thank you.
Great, thanks, Alison. Charlotte.
Thanks. Darren, I know you've touched upon maternity, but I suppose there's just lots of things for me going on in maternity, like nationally, the unhappiness of staff and the crisis of everyone leaving, the fact that pregnant women are one of the groups that least likely to be vaccinated, the bits within the report about induction in terms of, are we looking at harm? And I suppose then for me, the kind of equality lens of the fact that postnatal and antenatal care was already pretty poor before COVID, and now is even more of a real dearth because, those that can afford would definitely, you just pay for things because, it's the obvious area to cut services. So there's so many different elements. And I suppose with this being my last meeting, my request would be to bring it back and spend more time as a governing body on the kind of maternity journey and just unpick some of the different multifaceted parts that the link into health visiting services and how continually disjointed that is, has been forever. So from a system, so I think I don't expect you to sit down and answer all this now, but I would say there hasn't been a time, I don't think, since I've been on the board where we've had a more in-depth look at maternity. I think one of my first meetings we had a sort of touch point on it, and I just feel at the moment there's so many different elements to it. It would be really good to have a wider discussion on those different parts. So thank you for the update. It is an area of concern for me, and I'd just like to say it'd be great to see it come back with some more depth and across a sort of broader range of areas, because I feel it's an area of concern.
Yeah, thanks, Charlotte. And I think, as you will hopefully see in the report, the aim is to do a deep dive within each of the reports. Obviously, this time we did mental health, so I'll make sure that I go back to the team that will make sure that the next one, or definitely the January one, will be a deep dive into the maternity elements, and we could do that through the learning with the local maternity and neonatal system as well. Okay, great. Thanks, Charlotte. Glynis, please, and then Nick Kennedy, and then David Greenwell.
We heard earlier, Darren, that it was helpful because the pressures were under to perhaps call on the voluntary sector to support us. And I just wondered to what extent that was happening and how that's being resourced. I saw an article on the BBC about the Red Cross, for example, working with frequent A&E users to reduce that pressure. And are we looking at programs like that?
Yeah, no, absolutely. So we are looking at that. Particularly, there are again some good models in West Devon already established, and other areas following quite quickly suit. So I think absolutely the Red Cross report that's been published, I think today or yesterday, does point us into some other directions, particularly around high impact users. We're also looking in terms of, we know how our local authorities are also working with local community groups in terms of supporting, in addition to care packages. So those areas are working really well. We've also been looking at other models. So there's the model that's well established in Somerset that we are also testing as well. And we also know there was an opportunity to apply for additional funding we're just waiting to hear, absolutely to focus in those particular areas. I think one area of caution, though, is what we do hear from a lot of our voluntary sector organisations is that we know that we have our own quite rightly workforce challenges. The voluntary sector have their own workforce challenges as well. So I think there is always that word of caution around those particular areas that absolutely need to work hand in hand as an ICS. That's absolutely the model that we need to go down. There are equally workforce challenges in that sector as well as our own both paid and unpaid volunteers.
Thank you for that. I just wonder, your report, I don't want to make it any longer, but because it is really good and really comprehensive, but there might be a section on working with others and how we're drawing in support from non-NHS sources. Yeah,
happy to look at that.
Thank you.
Okay, thank you. So now we've got Nick Kennedy, please.
Thank you. Hi, Darren. Great report, actually. I really like it. Just a quick one. The community urgent service response, which started in November, how quickly is that likely to produce meaningful results? And can you quantify how much it's likely to, what impact it's likely to have? Have you got an idea?
So we're looking at the moment. So I'm hoping, I can't give you absolute numbers now, Nick, but I would hope in the December report that we'll be able to quantify that. We are starting to see some, actually some really early shoots in terms of real impact in those areas. So I would hope that in the next report, it'll be able to articulate or at least quantify some of the impact of that.
Okay, fair enough. I'm a bit early to ask, perhaps. Yeah. Thanks.
David.
Yeah, I just wanted to have a quick, more detailed look at the ambulance handover figures. So if you think about Plymouth and Torbay, just two of our hospitals, the figures seem to suggest that there's 1,500 episodes of a greater than 60-minute wake each month. But that equates to 50 a day, which must be well over half of all ambulance attendances waiting more than 60 minutes. And that's in the context of SWAST being the second worst in the country. So we've got probably more than half of our ambulance waiting more than 60 minutes. I just wondered what mitigation. So those patients sitting in ambulances waiting to get to the door of A&E, how are we keeping them safe? And then secondly, do we have any evidence that people waiting longer for the ambulances that are sitting in A&E are not coming to any harm?
Yeah, thanks, David. So I think there's a lot in there to unpack, and absolutely. So in terms of ambulances waiting outside EDs, absolutely, we're doing and working with all of our colleagues to make sure that is avoided as much as possible. However, as you quite rightly said, those numbers are exceptionally high at the moment. So we're working with SWAST around different approaches in terms of divert type models about how we work much more as a system across the 4 EDs in Devon. But what we also know is that our consultant colleagues within our EDs will continue to review patients in ambulances. We'll make sure that potentially we're looking at the moment around potentially pod models and what they call a hospital ambulance liaison officers. So basically in terms of a number of individuals being observed and managed, any delay ultimately is not ideal. It's suboptimal from a point of view in terms of patient experience at best, and obviously in terms of definitive treatment at worst. So I think absolutely that's an area that we continue to focus with in all 4 of our localities. So I think that area is one to absolutely watch and see the impact on that. I think, in terms of the delays to ambulances, ultimately ambulances then being held at A&Es, that there is no doubt that we are now starting, or the South Western Ambulance Service are starting to see and starting to be able to articulate harm that may be caused by individuals that are then not able to get an ambulance quickly. Obviously, the Association of Ambulance Chief Officers published a report last week that is very articulate about the potential of harm in those particular individuals that are over 60 minutes. And I know, Glynis, we've been having conversations through the Quality Assurance Committee in that absolute area and continue to work to show what we're doing and improving.
Okay, thanks, David. And then Simon Kerr, please.
Yeah, I wondered, Darren, you've got a figure in there for GP referrals are still, I think, something like 25% down on what they were in 1920. Is that real? It doesn't feel like that. And if it is, why is that? Is that because we're working in a different way? People still aren't coming forward, telling us that they need to be referred, or are we behaving differently? Are patients behaving differently? I see 2-week waits are up, but the overall referral rate's still very much lower than we used to make referral numbers at.
Yeah, and so we've validated some of this. We validated all the data on a number of occasions, and that does seem to be the number. Yeah, and I absolutely agree. It doesn't feel like that, and I'm sure it doesn't feel like that on the front line. And I'm sure Joe might want to come in on that. But I think what we need to do now is to understand, with some of these elements as we start to articulate the fine level of detail, is to really drive behind it and actually get into the so what question. So to really understand, I think we're definitely not there with the primary care element. I think there's no doubt COVID has changed behaviours, changed expectations, but actually is that a true contributing factor to those numbers? I couldn't give you that commitment here at the moment. Chair, I know Joe's hand's gone up, so whether Joe wants to just add something on that particular area before we come to David.
Yeah, thanks, Darren. I just will briefly add a couple things. So you're absolutely right, Simon, in terms of different routes in now and different ways of working. So what we know is that all the practices have varying ways of recording the activity and the work that they do, particularly when it comes to something like e-consult. So that isn't probably particularly well reflected here. We also know if we pull out and extract some of the local data, it will give us a different answer to this information here. So what we've done as part of the Winter Access Fund that we've received as an ICS, we're putting some of that funding into data quality posts that will work with individual PCNs, because we do need to get the national data right and the recording of this right, because it will actually be a really useful tool for us in terms of understanding the pressures on primary care, but also the pathways and the ways that people access care in the future. So I'm hoping over the next few months we'll be able to recruit into those posts and be able to do some work so we really understand and start to get to grips, as Darren says, with this data, and it needs to be much more useful in the future, so that should help.
Okay, David, is that a legacy or have you got a new question?
Sorry, must remember to lower my hand, sorry.
That's okay. So shall we take a very quick comfort break? Perhaps be back by 1:10, please. Okay. Right, shall we continue? Moving on to the EPRR core assurance standards. Ginny, please. Or is it Andrew? I'm not sure.
It's me, Chair.
Okay.
Yeah, thank you. If I just take you through, so obviously once a year we go through, both the CCG and all organisations go through an annual emergency preparedness and resilience assessment with NHS England, and the report highlights both our compliance and obviously those of our organisations. So Phil Cootie and Phil prepared all of the real hard work and met with every organisation, but Phil and I met with NHS England's regional emergency preparedness lead Ian Phillips and Neil Vine, in fact last 2 weeks ago, and they have fully endorsed our assessment. But if I just take you through just some elements, because I'm conscious of time, Chair. So in terms of the CCG as an organisation, we have been assessed, you self-assessed, and then obviously that's challenged by NHS England, but our self-assessment against 29 core standards are fully compliant. And there are things around whether we've got a plan in place, what we do in terms of if there was an incident of any fashion, train crash, loss of office, etc., etc. There are a lot of compliance standards that we have to meet, and even more compliance standards that our providers have to meet. So in terms of the CCG fully compliant, you'll see there a range of compliance by organisations, but the one I thought I'd just highlight is the one that we had most of the discussion with, and that was around Torbay and South Devon's compliance, which was only partial. And the reason for that is as part of the 46 core standards that they have, so it's much more detailed for providers. They were only green on 36. Now, a lot of that is due to the fact that they didn't have any emergency preparedness personnel in place for a large portion of the year, and that's now been addressed. And there were some concerns around whether they had an incident plan in place, and particularly elements of how they were preparing themselves. For instance, given, as you will be aware, Torbay probably have more incidents in terms of things like loss of IT and infrastructure issues than anyone else. So Phil and I have re-met with Torbay, and we're pretty confident that with the new lead in place that they will address the standards, 10 of the standards where they went compliant, and that will no doubt then help them move forward during the course of this year. And as you'll know, all boards have to take this compliance paper through their own individual boards, as I am now with the CCG. So I'm happy to take any questions, Chair, on that, but our assessment, as I said, was fully agreed with and rubber stamped by NHS England Regional Emergency Team.
Okay, any questions for Andrew on that very comprehensive report? Nick Kennedy, please.
Thank you. Hi, Andrew. Just around the Torbay issue, the way it reads is it says that it was found to be non-compliant following a major incident. Does that mean they thought that it was all right beforehand, and actually the stress of a real live incident found them wanting? And I guess the question from there is, how much assurance have we got that we or any of the other organisations who assess ourselves as being okay actually would stand up to a major incident? Is my reading of that right?
It's partly right. I mean, obviously the true test of your plan, Nick, will be a real live incident, and they've had a number. So obviously, they lost some of their theatres, they lost their IT system, and indeed very recently lost 2 of their cath labs. And most of that is to do with the really old infrastructure in Torbay. So I always worry when we have severe weather, because it tends to have an impact on some of their IT servers and indeed some of the air equipment. So I think that they didn't have a brilliant plan in place, Nick, because they didn't have anyone there to do it. They've had their standard plan in place, but I think it was through the real life couple of examples that I think their plan was found wanting. However, they've got somebody new in place now. They've been through the plan and adjusted it, and Phil and I are going to have a follow-up meeting with them later on during the course of the year. I'm pretty confident that with the new lead in place, as our NHS England, that they could probably cope a lot better with a major incident than they have done in the past.
Okay, thanks, Andrew. Graham, please.
Thank you, Nick. Just a quick question, Andrew. It's just about mutual aid. Clearly, any organisation could lose key members of staff, not just Torbay, others could as well. And I'm sure other organisations would leap to help if they could. Do we have a formal mutual aid system response, or is it just left to informal arrangements?
Yeah, no, there's formal responses on a number of fronts. So in the emergency preparedness world, there is definitely a mutual aid thing that's in place for all organisations to help each other out. And indeed, we've sort of done that in the past. We've supported Torbay, for instance, when they've had a critical incident. And of course, there is a mutual aid agreement in place from a clinical point of view as well, Graham. So I think it would capture both elements of them experience, or whoever experienced an incident, people would be helping out.
And does that extend regionally to colleagues in Dorset or Somerset, Cornwall, should it be necessary?
Yeah. Yes, it does. I mean, I think if I reflect on a lot of the issues that happen when you're on call, and Simon's done probably more than that than any of us, there is often discussions about support from organisations outside of Devon. For instance, I know when I was on, there was a transfer of patient, for example, to Taunton, an ICU patient with COVID. So we're pretty confident, I think, that if there's ever an incident anywhere in the southwest, there would be mutual support and aid.
Thank you.
Great, thank you. Okay, I'm going to move us on then to Plymouth West End Wellbeing Hub. Joe. You're on mute, Joe.
Sorry. Yeah, thanks very much, Nick. I think Nikki's just going to try and pop the slides up. Just to let you know, we've got Clive Shaw with us again this month, who's obviously programme directing this for us, which has been hugely helpful. Thanks, Nikki. So I think probably first thing to say is that this has been here. I think it's probably the fourth time we've brought this here now to the governing body. But really important, obviously, that we keep you very up to date with the work that's going on, but also in particular a couple of updates since the last time we came. So I think the first thing is, one of the things we do want to go through is go through sections of the mini OBC with you. So you will know some of those, and some of those will be very familiar, so we will go through those rather rapidly. But some of that, so particularly the financial case affordability, we've moved on quite a bit since last time, so it's really important, I think, that you have an overview of that here. So we will cover that. Also, there are 3 recommendations that we're asking the governing body to approve as well, so we'll come to those a little bit later on. But the kind of main reason why we're here is that we do want to submit a planning application. So it's really important that governing body are happy with the progress that we've made. Obviously, we're not asking you to make any sort of commitment here today, but we do want to put in a planning application, and of course we want to make sure that that's the right one, and we want you to be assured of the amount of work that's gone into doing that, and of course the financial case for change that sits behind that as well. So I'm going to take you through the first couple areas of the mini OBC, and then I'm going to hand over to Clive. And then I'm going to hand over to Ben Chilcott, who's also with us, to take us through the financial case as well. So just in terms of general progress updates, obviously, as you can see, the mini OBC is underway. When I say mini, it's about 100 pages long. So we did have a debate about whether we shared that with governing body, but we felt there was just too much there to realistically ask you to review all of it, although very happy to kind of circulate that after the meeting if that's helpful. But we have got a summary for you here now. Well, obviously, as I said, we are at the planning application stage, and we want to be able to submit that on the 16th of December. We are very close to agreeing the tenant schedule of accommodation. So as we say there, 95% agreed. We've now got all but one letter of commitment as well. So what we're asking partners to do who want to move into the health and wellbeing hub is at this point sign a letter of commitment that they do want to do that. Obviously, we're not asking them to formalise it beyond that at the moment, because of course we're still going through planning, etc. But that's really important that we've got that. I'm really pleased to say that we've got all but one of those at the moment. We have scrutinised the timetables. That has led to a slight change. So obviously we're working with a national team as well on this, and we have to kind of be bound by their timetable as well around reviewing the business case and signing off the business plan as well. So we have slightly moved that, as you can see there. Ongoing focus, as you would expect there to be, in terms of the scrutinising the finances on this, but also that low carbon and the modern methods of construction as well, which are really important from a national perspective, but also, of course, from a local perspective as well. So we have got some risks that we will highlight to you later. I'm not proposing we go into any detail on the risks, because they are being managed at the programme board, which I chair as the SRO. So some of those risks have been escalated up to me, but we are dealing with them. And I'd like to say working really closely with the local authority and the national team as well on some of these risks. So nothing that we're escalating at the moment to you, but it's important that you're aware that there are some risks. Okay, Nikki, next slide, I think. Okay, so the strategic case for change. I'm not going to dwell on this too much because you've seen it here before, but just being really clear about the makeup of that strategic case for change. So you'll know this is one of the most deprived wards actually in the country, let alone in Devon or Plymouth. You can see there very clearly the demographic information, but also how we compare to other wards in Devon in terms of access for these patients and also quality and outcomes for these patients as well. Okay, next slide, Nikki. These are the investment objectives. Again, we've brought this here before, so I'm not anticipating going into any detail. One thing I will say, though, is one of the conversations we had here last time was about the amount of detail that's needed to really work up. How do we know that this has been successful? So what does success look like to us? How do we quantify it beyond the measures that we are that we've articulated on here? How do we quantify those measures, and how will we know that we've been successful? What will be different? So we've got a workshop that will happen in January. So in the new year, clinicians will come together along with obviously others as well to design what those measures look like. And we want them to be far reaching as well. So not just those traditional measures that you might usually think of. Okay. Thanks, Nikki. So I'm not going to go into the model of care vision. I think one of the important things to say, because you've seen me say this before, and nothing in here will be a surprise, but we do have a clinical case for change that sits behind this, which Richard Ayres, one of the GPs, is our clinical lead for this programme of work, and he's been working on that with others. So Jonathan Cope as well from UHP as well has been working on that, and I think that gives us a really good solid platform in terms of articulating what we're trying to do here and what will be different, and again we'll be very happy to share that as well. Okay, next slide, Nikki. Okay, and this is just a description of the hub itself, so how this fits into the overall offer within the city, so how this fits into the universal offer that is available, broadly speaking, across the city, targeted offer, and this being at the very top end of that out of hospital community support offer. There is something, and Clive and I have spoken about how we need to articulate specialist in this instance and what that means to us in a broader NHS context as well. So I would think of specialist as being that tertiary centre where you only go when you need to go, whereas of course this is a broad description of what sits outside in terms of community assets and health and wellbeing services. So there's a little bit of work just to do there on the description. Okay, next slide, Nikki. Okay, yeah, I'm not going to go into a great amount of detail on this one because you've seen this slide before, but it is worth saying we've done an extensive amount of engagement. So leading up to really starting to put the business case together, so May to July earlier on this year, working very closely with our partners, communications team, and also should mention Nudge as well, who are based in Plymouth, and have really helped really get the public's voices into this for us. We've done an extensive amount of engagement online and in person, and also the GP practices have undertaken their early engagement as well, and overwhelmingly it's been very positive. There are some things that people would like to see in the centre, and we've tried to accommodate as much of that as we possibly can. You're never going to accommodate everything, but I think broadly speaking everyone is really positive that this is a really good thing for the city, and bringing all those services together will ultimately have a better outcome for patients and citizens as well. Okay, next slide, Nikki. Okay, at this point, I'm going to hand over to Clive, who's going to start to take us through some of the more technical elements of the business case.
So, Joe, would it be Joe? Sorry, Clive, just before we go on, would it be a good idea to pause there in case any questions for you, Joe?
Yeah, very happy to do that.
Okay, has anyone got any questions for Joe?
No, I think hopefully most of what I've said you've heard before, to be fair.
Yeah, so something struck me. Are we going to keep a list of those things that people requested that we haven't been able to put into the centre? Because I think it would be quite good in terms of when we come to consult with the public, you know, just to honestly put up these things were asked for, and, you know, they were only asked for by 3 people, or they're asked for by 200 people, and we still couldn't do it for this reason. Yeah, absolutely. And what we've done, because obviously we've been, as you say, we've done a wide amount of engagement on this, and we have already done a little bit of a sort of you said we did. And obviously we've also been working with local councillors, MPs as well,
So we have a list of things that we've not been able to accommodate, although I have to say it's really small. So most of the things we've accommodated within the centre, and that fits in with that sort of clinical case for change, really. But we do have that, and we can articulate that, and I think that's really important in terms of any future engagement that we want to do when we get kind of nearer to that, the early part of next year, and any potential consultation, then that will be really important, Nick. So yeah, thank you. Good point.
Okay, Simon, please.
Joe, can I just ask? So it's owned by the Integrated Care Board, this structure, but who actually is the sort of employing body that employs the general practice staff? Is that going to be, or do we not know that yet? Is that something to be?
So none of that will change. So the CCG at the moment, because the CCG is the body that's in existence, will own. But of course, by then we should be the ICS and the ICB, and they will own the building. But that won't impact in terms of contracts and employment with those individual organisations. That will still happen at the moment, as that currently does. So practice staff will be employed by practice staff if that's how they are now. Of course, unless of course we agree slightly different models that would be in line with anything we wanted to do in terms of improving the care pathway in the future.
Have we got any precedent for how that works? I mean, 3 GP businesses all under the same roof trying to work together. It just sounds like really challenging. I mean, I think the whole idea, having worked in Plymouth and not far from where this is a really good one. And I know that, for all the arguments that you've made, but I just wondered, as reflecting on what Sheila was saying, I think earlier, about clinicians working in a massive organisation where you kind of sort of don't necessarily belong anywhere, how this really will make GPs feel secure working in such a structure, and who will be their management structure, and will it actually ultimately force the management structure of the practices to merge? I don't know. I suppose that's all speculation.
There's quite a lot in there, Simon, but nothing. So from those individual practices' perspectives, nothing will change. So they won't be managed by different individuals. They'll still be employed by their individual GP practices. So none of that will change, unless, of course, through working in an integrated way, they decide that is a benefit for them to do. And of course, we've seen PCNs come together, so practices come together under PCNs, and actually that's provided a great deal of support. And actually, if you ask practices now what they think about the PCNs, what they think about PCNs as a construct, actually it's been hugely positive in terms of the benefit that's had. So I don't see that being a threat, but I do see that potentially being an opportunity in the future.
Okay. Let's move on then. Clive?
Okay. Yeah, completely agree with that. Right. Hello, everybody. So the economic case. So in the mini OBC, there is a very detailed process which is aligned with the Treasury Green Book process for setting out how we've arrived at the preferred option for the service scopes, the services in the building, where it's going to be located, how we're going to procure the contractor, whether we're going to do it in phases or in one go, and how we're going to fund it. The upshot of all of that is that the preferred option is for a wide range of services, the 3 GP practices that we've talked about, but community mental health services, outpatient voluntary services. The preferred site is on the Colin Campbell Court car park in front of Colin Campbell House. We looked at other options, but this was the only one that really worked because there was a significant planning constraint regarding Colin Campbell House. So we couldn't knock it down and we couldn't keep the facade. Therefore, it was really a new building elsewhere on the car park site. We've been mandated by the national team that the contractor framework has to be through the P22 framework. I'll say more about that in a moment. It makes sense to do it all in one go rather than phases. And the funding is going to come from NHS public dividend capital. So if we go to the next slide, please. So you've seen this before. So this is a summary of all of the services. So as Joe said, we've now got formal letters of commitment from all of the major tenants of 3 GP practices, UHP, Live Well and Citizens Advice. The only one that is outstanding at the moment is from NHS England as a specialist commissioner on dental, but they have approved the schedule of accommodation and are very happy with it. So I'm expecting that letter today or tomorrow. So that's a full house for us, which is really very encouraging. The other specialist providers there won't be taking core space. They'll be taking bookable space. We are in regular contact with them, and they're happy, but they won't be signing a lease per se, so they don't have to have the letter of commitment. And we're going through a process to select the pharmacy, so that's all on track as well. If you can just go through the next slide, please. Next few slides you've all seen before, which are the building layout. So I'll just really quickly go through. So pharmacy bottom left-hand corner in pink. Then you've got the diagnostics, and in the diagnostic side, there's a door in the bottom left-hand corner, which will allow for out of hours GP services. And also, if required, we've slightly changed this. You haven't quite got the latest version there, but we've created it so there's a area for COVID patients to be seen as a hotspot for the hot site by the GPs. Up at the north end there, you've got the voluntary sector. To the right hand side is the cafe and the community kitchen, and the whole idea of the ground floor was to create a sense of a street feel through the middle of the building, which then can be used for events. We can have information kiosks in there, you can have blood pressure taken, range of different things that can happen in that central street space. Next one, please. So this is the middle floor. So the top left is the UHP outpatient space. The bottom left is North Road West. Bottom right is Armada, and top right is Adelaide. Now there are some shared spaces in there as well. So some of those spaces are shared between the practices, and there's some collaboration rooms again where there is shared space. You see the staircase in the middle, and that's where patients would encourage patients to see the stairs first rather than the lift, which is something that came up at one of our previous meetings. Walk up the stairs straight into the reception area, and then a range of subwaits. I was also encouraging people who arrive particularly early to wait downstairs. And next one, please, which is the top floor. So we've got the dentistry at the bottom left. At top left, we've got the GP admin space. At top right, we've got a mixture of seminar meeting room space, which can be opened up so there can be a big meeting room. And then the little dotted lines you see, there are discrete sort of phone booths for quiet conversations. And then in the middle on the right hand side is the shared dining area. So that's for all tenants in the building. So great collaboration space for people to come together. And then in the bottom right, you've got two things. We've slightly modified this in this version. So there's hot desk areas, and then we're also going to create a bank of 6 desks for GPs to do online consultations, which either they can do, they can book sessions if a GP practices want to do it separately, but if they did then want to do it together, there's that function as well. Next one, please. So artist's impression of the aerial view, and then I think that a couple of things I think I probably should point out on this. We did find out. We found out yesterday, bizarrely enough, that there will have to be a couple of front steps at the beginning because of the new Environment Agency flood protection. All buildings have to be 3.9 metres above sea level due to climate change. So we are going to have to put in a couple of steps in the ramp, but we can do that. And between the building and Colin Campbell House, you see that green space. quite a lot of conversations going on with the local planning authority at the moment about the nature of that green space, because it's quite important to us that we want to create that having much more of a garden feel and a public realm feel, and that's something that's ongoing at the moment. Next, please. That's a street view, minus the steps, which we're going to have to put in. And then the next one. So if I just do the next case, which is a commercial case, then I'll stop for questions, if that's all right. It's just a couple of slides on this. So we've talked about the building will be owned by the Integrated Care Board as a legal entity, so the first asset that the ICB will own. The key things around the tenant space is that people occupy space on one of three bases. Core space, it's only used by them, and we want to minimise that amount of space. Guaranteed sessional space, which we really want to try and maximise compared to the core space. So tenants might say, I want that space between 8 o'clock in the morning, 6 o'clock at night. Anybody else can use it after that. It'll be up to, we talked about this last time, it will be up to the tenants to define how long they want that space for, rather than it being mandated to them, and then normal bookable space. So what we're trying to do is to make the building as flexible as possible. As Ben will talk about in a moment, building costs are met at the ICB level. That means that it just increases the flexibility of the space. We're not trying to have lots of recharges around the place. We know what the building will cost, and therefore we have to make sure that we're delivering sufficient benefits in order to fund that cost, and significant outcomes over and above that. We've talked about letters of commitment. The next stage before the full business case is agreed in August, it will come back formally to this group in July for detailed review and confirmation. And at that stage, the occupiers will be asked to sign an agreement to lease, which will then accompany the full business case up to the national team for formal approval. Go through the next slide, please. Just want to say a couple of things about the P22 framework. So this is a national framework from the Department of Health and HSEI. It's only got 6 contractors on it, and there's a very formal process for going through it. I have a meeting this afternoon with the six firms as an initial explanation of the scheme. I'll be joined by Andrew Mitchell, who's the national P22 lead. We then issue a high-level information pack. It's like an expressions of interest document to the 6 on the 13th of December. They're coming down to Plymouth on the 16th for an open day. And the next slide, please. We give them until the end of January to respond to a whole series of questions that we're going to ask them. And then we're going to set up a panel, and we will interview the 6 or however many have expressed interest at the beginning of February, so that by the 11th of February we will then have our P22 partner. That partner then works with the design team to come up with a guaranteed maximum price. So by the time we submit the full business case, and by the time we come back to you with the detailed business case in July, we will have full planning permission, and we will have full tender costs. We will know the guarantee and therefore the affordability threshold of the scheme. Next slide, please. I've only got 2 more, and then I'll take questions. So we, as part of our P22 process, we are mandated to ask 4 questions that have been set by the national team. We did have quite a lot of involvement in these questions and consultation. Didn't take all of our advice, but we're happy with what's come back. So questions around BREEAM and sustainability, standardisation and modern methods of construction, which is a big issue for the national team because they want the 6 pioneers in the Cavell programme to be the pathfinder for a national network. Therefore, getting that standardisation right through the 6 pioneers is really important. How they're going to work with us and the benefits they're going to provide to the local economy of Plymouth, and their responsibility for sharing information and working with the other pioneers. So those are the national questions. The next slide is we're also allowed to ask 3 local questions. And the 3 ones that we have come up with, we might change these and slightly modify these over the next month. But the main focus of the questions are all 6 will have very detailed experience of working in health. What we want to know is who's the team, who are the actual individuals that are going to work with us, how are we going to be assured that, that those will be the ones that will actually start with the project, and what's the business continuity processes in place. How are they going to work with their supply chains? You know, the market's incredibly tight at the moment, prices are rising. It's difficult to get the right people. So what's their supply chain strategy? That's going to be really important. And how are they going to work with us on the cost management? So those are the 3 that we're anticipating. But as I said, those are still out for consultation. I think that was the last one on the commercial. Can you just check that the next slide says finance case, please? It does. Yeah. Good. A few. Happy to take questions.
Okay, we're badly behind with time, so if you could make both questions as succinct as possible, please. Sheila.
Thanks, Clive. So my question relates to a presentation that we had earlier from a lady who speaks on behalf of deaf patients, and it just made me think about how we ensure that this building is as disability friendly as possible in terms of signage and accessible toilets, and you mentioned ramps and so on, and I'm sure that that's all been thought of, but it's really important that we do look at it a couple of times to make sure that we don't miss anything.
Yeah, so we do have an independent design panel that are advising us, people from universities of Plymouth and Newcastle, and we are bringing onto that panel representatives of particular design expertise at the moment from dementia and RNIB, but we'll also look at others as well. So I'll take on board the deaf point you've made, and just make sure that we're covering all of those angles as part of our design panel.
Thank you.
Thanks, Clive. John Walmsley, please.
Thanks. So, Clive, this is fantastic, and we're all watching you. When I shared the plans with council colleagues up in Northern Devon, they were very, very interested. So, how well this works will be interesting. I'm just looking at the middle floor, Clive, and we did something on a much smaller scale in Ilfracombe where 2 practices came together.
Yes.
And we had a building with an atrium, and we found that we ran out of waiting space, and we had to fill in the atrium and fill it with waiting space. So are you really sure, when I see the number of rooms on the middle floor, that you've got enough waiting space? Point number 1. And point number 2 is from a sort of running a practice point of view, we found it essential that we could observe the waiting area, because sometimes
yes,
sparks can fly and that sort of thing. So waiting to fill these rooms for the general public. Have we got that properly sorted?
So the short answer is I hope so. So the waiting areas are observable from a reception. The thing that will make it work is the ability to use technology appropriately, so that if people are arriving early when they check in, they're told to wait downstairs, and then through a buzzer system, and then be told to go upstairs when it's their time for their appointment, or close to when they're the next one in. So you'll have one person in the room, the next person waiting. If there's then somebody that has then arrived, they'll be told to wait downstairs. There's always the challenge. People don't necessarily do as they're told, but I understand that risk.
I think there's a little bit of a risk there. Okay, Clive, thanks very much.
Thanks. Simon Kerr, please.
Yeah, thanks. So thanks, Clive. I might have missed the point of Cavell Centres, but knowing where this is, so just around the corner from Union Street, I think, are we missing either an opportunity, or are we going to end up with a problem in that people are going to just want to walk into this place and present their minor injury, or and is there therefore a facility for resuscitating people who collapse on the ground floor in the atrium? I just worry we're going to get customers coming in here or who are expecting it to be something that it might not be.
And that's a good. That's a good point, because it's not a walk-in centre. We haven't done the detailed equipment yet, so we will think about the resuscitation, and it'll be critically important for the signage and the directions about where is the local walk-in centre, which I think is the Cumberland Centre, which is I think it's about a mile away.
So, Simon, are you aware that since you worked there, Union Street has gone from being fantastically busy to dead quiet? Because there's been a completely change in the structure of the way that bit of Plymouth is run. So there are no nightclubs on Union Street anymore.
Oh, right. Okay.
Radically different from the bedlam that used to be Union Street 20 years ago.
Simon's upset.
All right.
Okay. Do you want to move on to Joe? Sorry, Joe. Do you want to move on to Ben?
Yeah. Ben next. Yes. Hello, thank you. Yeah, so I was just going to go through the finance case and look at this probably through three lenses. One is around the capital case, one is around revenue, and one is about the overall affordability and the cost benefit analysis. So in terms of the capital costs, the slides have been there and you can see the numbers. So the overall cost about 36.8 million as identified at this point. So there's still a bit of work to do around value engineering around that, but it does include an optimism bias and VAT. So it's a kind of an all-in cost. In terms of how that compares to what we were given in the first place, NHS England identified a pot which was a fair bit lower than that, but I think they, in conversation that we've had with them to date, they recognised that that their initial assumptions were actually fairly low, and all of the cases are coming in higher than their initial estimates. And they recognise that we're about in the middle of the pack, so this seems reasonable. They're happy that this is a reasonable cost. As we've been talking about, the building would be owned by the ICB, with ownership comes a number of different impacts in terms of the ongoing capital and revenue. So the first is about the overall depreciation. So depreciation is essentially writing down the overall cost of the build in the first place, and you do that over a period of time that we've identified for this case as 60 years. That's longer than you would normally depreciate a building. And that's because one of the novel things about this building is, rather like lift buildings, the funding is there to maintain it. So the fact that the way it's built, the BREEAM excellent, sustainability, all that sort of stuff, net zero carbon, that will all impact on the sustainability of the building, plus the fact that we look after it and we maintain it will enable it to last for the 60 years. So that's why we depreciate it over the 60 years. That does have a revenue cost to it, which I'll pick up in the revenue section. So the second bit then is around the life cycle costs and the maintenance, so maintaining that building. CCGs and ICBs, because they don't to this date generally own assets, don't have an ongoing capital programme. So we need to work with NHS England to understand that there will be a capital programme to enable us to fulfil the life cycle costs. So we've identified what those life cycle replacement costs would be over the 60-year period. They do vary, they go up and down, but the average is about 200k per annum. But again, we're working with NHS England to ensure that the capital is available on an annual basis in order to do that, to maintain the building, which will keep it in good order for the 60 years. Third thing, there's probably four things I wanted to pick up here. So the third thing is around an impairment. So at the point at which the building is completed and we put it onto our balance sheet
dogs are going to bark, sorry. We'll look at the valuation of the asset in order that what we're reflecting on our balance sheet is a fair representation of the actual net book value of the asset. Generally, that is lower than the build cost, and so we're likely to hit an impairment on day one. An impairment is essentially it's a bit like ultra fast depreciation, and so it's a revenue hit. So it could be quite significant. And again, this is something that because CCGs and ICBs, well, ICBs don't exist, but CCGs haven't had significant assets, we haven't had to deal with impairments in our current finance regime. So we do have experience of it previously in PCTs and experience of how the financial impact has been dealt with. So we've got that experience. We're working with NHS England to see if we can apply what happened with PCTs equally to ICBs. Essentially, that's treating it as a technical deficit, and so it doesn't impact on our control total. The fourth thing around capital costs is the VAT. So as I said, the 36.8 million includes VAT. We're working with the national team to see whether there's any opportunities around the VAT, how the VAT is applied to the build costs, and therefore whether there's an option for us to tax or not tax any lease costs at a later date. And that's important because of the novel nature of how we're expecting to lease these premises to the tenants or the users of the building. So that's it around capital cost. In terms of the revenue, if you move on to the next slide. So in terms of the revenue, excuse me, move on to the next slide. So as set out there in the middle of the right hand side, there's an overall saving to the system of about 200k. So in revenue terms, on an ongoing basis, this is affordable based on a set of assumptions, and I'll go through what those assumptions are because they are important, and they'll be part of the case that we need to set out to NHS England in order that they understand what assumptions we have made. There is an organisational impact of that 200k of savings, and we'll run through that again in a minute. So the reason why it's affordable generally is because we've got reductions in costs for the GPs, Livewell and UHP. What we need to do is ensure that we understand whether there's a real cashable savings, whether they're part of those providers' overall SIP programs, or whether those savings are going to be reinvested in other services, or whether we will actually transact the savings into the ICB CCG in order to make this revenue neutral. So that's something that we will continue to work through and negotiate with those providers as we work through this process. We talked about depreciation earlier. So the depreciation of the 36.8 million over 60 years is 600k per annum. This case is built on an assumption that that is funded. So the assumption is that essentially we would get additional revenue funding to cover off the 600k of depreciation. In reality, if that were the case, I suspect that NHS England would look at the overall revenue benefit above the 200k, and they'd only fund us the difference, being 400k, to make it break even. So I don't expect us to be making a profit from this. When I say a profit, a saving, overall saving. So that's part of the case. Similarly, for generally for assets and capital spend, the provider sector have to pay capital charges on their net capital assets, 3.5%. That's not included in the finance regime currently for CCGs and NHS England, and this case is built on a continuation of that finance regime, i.e. there will be no capital charge of 3.5% for this asset. And if it is, it will need to be funded. So the assumption is both the cost of capital at 3.5%, which is about 1.2 million in the first year, plus the 600k of depreciation, are fully funded. Both the depreciation and the capital charges would be impacted by an impairment, so they would be lower, and that may be something that we can use to help us work through with NHS England. So that's it in terms of the revenue position, and that looks positive. In terms of the overall affordability, just want to move on to the next slide. So I think we've probably covered off most of that. The key thing there probably is the cost benefit ratio, whereas it says there it's over 5. So what we have looked at is all of the non-cashable savings and the wider societal benefits, and those have been costed up on an annual basis. So in terms of the non-cashable savings, those are generally around kind of reduced attendances, reduced length of stay, reducing DNAs, non-elective admissions, dental, ambulatory, reductions in all of those things as a result of this being in place and accessible. And then in terms of the wider societal benefits, we've gone through a process with NHS England, which they're running with all of the pilot sites, which identifies and costs up the social value for lots and lots of different wider factors around this, around employment, debt, rough sleeping, depression, drug and alcohol, reductions in all of those, or improvements in all of those things. So that comes up with a very significant social benefit over the 10-year period, and on an annual basis there, as you can see, 9.1 million. The overall benefit then is over 5, which is a significantly good score, and better than any of the other options. Don't think I've got anything. What's on the last slide? Oh no, probably we've got a quick analysis. I think I've covered off the risks and opportunities. Last slide then was about the organisational impact. It's set out there, but I think I've explained the key thing that we need to do with those is understand what we do with the savings. Sorry. What we do with the savings, in particular in the providers, and whether those are cashable or non-cashable, and whether those are reinvested or not. So that's the overall financial case. I'll pause there and take any questions.
Questions for Ben? Judy, and then Glynis.
Thank you. Ben, on the revenue costs, you've occasionally used this term, whether the benefits to these providers are cash releasing or not. But for me, these charges, utilities, the cleaning and everything, the 844,600 is actually real expenditure, real money we will have to pay out to run this place. And then you've said we're likely to be underfunded on depreciation because the government will assume the other extra 200k of savings. So therefore, it means that the reduction in GP costs, live well costs, UHP costs, and cash releasing benefits all have to be genuine cash releasing in order to cover those other costs. And not necessarily now, but I would, before we finally sign off, whatever it is we sign off, want to know that is definitely verifiable with the commitment of those other providers, because otherwise we will find ourselves paying an extra $1 million a year to run this without getting the cash releasing benefits. So I just would like us to come back to that at some point. When is appropriate, I don't know.
Sure. Do you want me to respond to that now? So you're absolutely right, Judy, and that's exactly what we're doing. So we're meeting. In fact, Clive and I have just been arranging a meeting this morning with Livewell to work through the implications with them. You're absolutely right. We do need to realise those savings in order to offset the overall expenditure and make it cost neutral as part of an overall system programme.
Thank you.
Okay, thanks, Judy. Glynis and then Simon, and then we must move on.
Thank you. I mean, I think my question is probably similar to Judy's. There are two big assumptions in there, aren't there? One's about the depreciation and that being funded, and the other one is about the capital cost, the interest cost being funded. When will we have the answer to that? When will we know whether when can those assumptions be firmed up?
So we have had verbal assurance from NHS England. We haven't had written assurance at this stage. We continue to work with the national team. You know, this is a groundbreaking national pilot. So I guess what we don't want is for us to be making different assumptions and this to fall over at a later stage. At this stage, I think we're as assured as we can be that the national team are committing to this.
But presumably we wouldn't go ahead unless we have this in writing, we have it confirmed.
Indeed.
Okay.
And that would happen at the full business case stage. So we would need something in writing for business case to confirm exactly what the pressure was on the system.
Yeah.
Thank you.
Okay. I'm sorry, Simon, but I'm gonna have to move us on because we need to make a decision about this, and board members are dropping like flies because people have got other commitments. That's my fault because I haven't kept us to time very well today, but we've had a number of discussions that I thought were really important. So, Joe, do you just want to say anything in summary of what the decision is you want us to take today?
Sorry, I couldn't come off mute yet. So the three recommendations that I think Nikki was just going to pop up, but basically the recommendations are for us to submit the planning application to Clive's going to have to help me with the other two, but basically to ask John and Ben, or to give John and Ben, sorry, the ability to award to one of the P22 constructions, and then also what's the third one, Clive?
The third one is well, there's a formal stage of just accepting that the CCG is happy to be the contracting authority.
That's it.
Yeah.
Thank you.
Yeah.
Okay, I'll just give everybody 10 seconds to read that, and then can we just confirm our support for it, which I'm sure is going to be absolutely unanimous. This is a fantastic project. I'd just like to thank Joe, Ben and Clive for the amount of work they've done on this. It's really, really looking good. So can I just check, has anybody got any objections to this? Oh, Glennis, you got your hand up. Glennis, no objections. Can we take that as?
No, it was a legacy hand, sorry.
Okay, all right, great. Thanks so much. Okay, so.
Thank you very much.
Thanks, Clive. I'm going to move us on to the local care partnership reports, and I'm going to take these as read. So what we had intended to happen for the first time this month was to have the locality directors present the reports rather than the locality GP. But unfortunately, all the locality directors have had to leave us because we've overrun. So I'm just going to take the reports as read, unless there's anything desperately urgent that any of the clinical leads want to add to those reports. So I'll just quickly go through them. The South.
Sorry, I don't want to take too much time, but I just had a couple of communications from the South this morning, just emphasising the fact that the very limited capacity that's available for non-urgent care, the consultants in the South are really asking for GPs to do everything they can to limit referrals because of the difficulty of handling those referrals. The request is that some comms be put out to maximise the use of advice and guidance and to look for alternatives where those are available. I'm not sure what response that's going to get from GPs, but I'm at least raising the issue that's been raised in the South.
Okay. Thank you, David. Perhaps I can ask Simon to come back to you about that outside the meeting.
That's an LCP issue, Chair. We put out messages sort of similar to that on a fairly regular basis, and it's about the LCP communicating well with its local GP practices, which I think should be sort of our day job, really.
Yeah.
I will take that forward as the South Devon and Torbay LCP Chair, Nick.
Great, thanks, Simon. Okay, Plymouth, Sheila, do you have any? I think Sheila's gone actually, so we'll take that report as read. Eastern, Simon, have you got anything to add? No, great, good answer. Northern, John?
No, Chair, I wouldn't dare. I wouldn't.
Thank you. And Western locality, again, Anna had to go, so we'll take that as read. So then we've got the committee reports. I'll take the same stance on them. So finance, Graham? Nothing? Audit, I've just got 7 things. No, I'm only joking. There's nothing for me to add to the audit report. Primary care, Judy? No, great. Quality, Glynis? Can't see Glynis. Oh, there you are. Okay. You're on.
Sorry, nothing to add. Yeah.
Great, thank you. And commissioning.
No, nothing.
Okay, that's great. Right, I'm really sorry for the rushed end to that meeting, but I think it was important that we spent the time on the items. Okay, so we have overrun by